So good evening, everyone. Today, we are going to be taking a presentation on pathogenesis and management of calculus cholecystitis. Dr. Uzo, a registrar in surgery, currently doing a general surgery posting, is going to be taking us through this presentation. And after the presentation, as usual, we are going to entertain questions, comments from other consultants in the group, then residents, and we are hoping that Prof will soon join us. So, Dr. Uzo, you can commence your presentation, please. Thank you.
Okay, good evening, sir. Good evening, consultants. Good evening, colleagues. I am Dr. Uzo from the Department of Surgery. I'll be taking the topic pathogenesis and management of calculus cholecystitis. Please, can you all hear me, please?
Yes, we can hear you. Go ahead and make your slide in a PowerPoint format.
Yes, it is, sir. It's in a PowerPoint format, sir. Okay, so I'll be talking about the pathogenesis and management of calculus cholecystitis with the following heading: the introduction, which I'll talk about epidemiology, relevant anatomy, and biophysiology. I'll talk about the etiology, pathogenesis, management, complications, and I'll conclude. As a way of introduction, calculus cholecystitis is the commonest cause of acute cholecystitis. It results from luminal obstruction of the flow of gallbladder content by gallstones. Cholecystitis is the inflammation of the gallbladder, and making a diagnosis needs high index of suspicion to attenuate complications that arise if left undiagnosed. Epidemiology of calculus cholecystitis is the most common cause of cholecystitis, common in the Western community. It occurs in 60% of women. And pigment stones are common in Asia and Africa. There are different types of stones, which I'll talk about later. It affects greater than 30 million Americans annually. It's mostly asymptomatic. Only about 20% present to the emergency. The relevant anatomy: the gallbladder measures about 7 to 10 centimeters long, is pear-shaped with an average capacity of 30 to 50 mils. It's located at the inferior surface of the liver along the Cantus line. The Cantus line is a line that separates the liver into left and right. Common bile duct and the inferior surface of the liver. These are arterial aberrations that are found in patients. The most common anatomical type is also the type A. You can see within the color triangle, the arteries move different arterial aberrations. The biophysiology: bile contains of 97 to 98% of water, contains bile salts which include the cholic and gut enzymes to deoxycholic acid and litocholic acid respectively. They make up about 0.7% of the bile, makes up about 0.5% lecithin and fatty acids. It also consists of inorganic compounds, bile pigments, vitamins, and electrolytes. Bile pigments found in the bile is urobilin, which is broken down to urobilinogen, broken down further, which is conjugated to urobilinogen in the gut, in the intestinal tract, and broken down to urobilin and stechobilin. The functions of bile include emulsification of fat, absorption of fat-soluble vitamins, and excretion of liver toxins. That's the function of the bowel. This is a diagram. I don't know if I can zoom in to show you this is a diagram showing the enterohepatic circulation that converts the bile acids, that's cholic and chenodeoxycholic acid, to deoxycholic acid, and also breaks down bilinogen to urobilin and steatobilin. The etiology of calculus cholecystitis, or the etiology of gallstone formation, can be broken down into altered gallbladder function, supersaturated bile, altered enterohepatic circulation. Now, in some books, they tend to divide it into metabolic, infectious stroke infestation, bile stasis, and obstruction of enterohepatic circulation, which are all encompassed in this, in the way I separated it here in the etiology. Now, alteration of gallbladder functions include stasis, or anything that causes gallbladder stasis. Can be infection, can be obstruction by gallstones, poor emptying, poor absorption, or infections. All these etiological factors cause the formation of gallstones within the cystic duct, which now occlude or prevent the draining of contents of the gallbladder and will lead to a sequelae of events, which I'll talk about later. So the types of stones include cholesterol stones. This makes up about 15% of the total amount of stones. Then we have the mixed stones. Then we have the pigment stones, which are either black stones or brown stones. The pigment stones form due to excess formation of bilirubin or excess or supersaturation of bilirubin within the bile system. Now, going back to supersaturated bile, the bile contains of lecithin, bile salts, and cholesterol. Now, if there is a mismatch within this ratio, the normal ratio of lecithin and bile acid to cholesterol ratio is about 25:1, with an alteration in this ratio to about 13:1. That's 13 mean lecithin and bile salt reduction, or increase in cholesterol level when the lecithin and bile salts are in stable concentration. It will lead to precipitation of these cholesterol stones, and the formation of stones begin. Now, it has been found out that people with high calorie values, and there's something they call 5 Fs of cholecystitis. It has been found out that females found out that females that have high occurrence cholecystitis, we have conditions that alter this enterohepatic circulation, which increases bile acid concentration in the body. Bile acids help to keep cholesterol in a soluble state. Without high concentration of bile acids, causes the formation of gallstones. So conditions or events that lead to alterations in these enterohepatic circulations, like ileal resection, ileal diseases, or rapid bowel, to use serum cholesterol level by preventing reabsorption of the cholesterol via enterohepatic circulation, can cause increase in cholesterol concentration within the gallbladder, thereby causing precipitation and stone formation. These are the etiological factors that cause stone formation within the gallbladder or the biliary system. The effects of gallstones. Gallstones, like I said earlier, are mostly asymptomatic, but they can occur in 10% of females, of males, and 20% of females. It can cause biliary colic with periodicity when there is an obstruction and subsequent resolution. There's acute cholecystitis, chronic cholecystitis, empyema of the gallbladder, as pus formation within the gallbladder. We have mucocele of the gallbladder, which occurs in the gallbladder when there is stasis but without infection, which causes glandular secretions into the gallbladder and formation of mucus within the gallbladder. It can cause slimy gallbladder. This is a condition that the gallbladder is filled up with carbon phosphate deposits. It can also have malignant transformations, and they can also be perforations of gallstones. So the pathogenesis of calculous cholecystitis, there is obstruction of the cystic duct by gallstones, which causes biostasis within the gallbladder, leading to a sequelae of events. Like I mentioned in the previous slide, it can be asymptomatic, they can resolve, there is empyremal pores formation, and inflammatory mass can form. Rarely, it can rupture, it can be gangrenous, and there is common hepatic duct obstruction. This is a rare phenomenon that can occur. It's called Mirizi's syndrome. There is accumulation of there's gallstone formation in the Hartmann's pouch, which now compresses the common bile duct and prevents hepatic secretion of bile duct. Take a history, surgical and management. In the history, we look at the biodata, which I talked about the 5 F's of cholecystitis, which include the fat, fertile, 40 flatulent females. Then the history of presenting complaint. Patients that have such conditions present with either epigastric pain or right hypochondriacal pain, which is sudden onset. It might be radiating or non-radiating. It's usually associated with meals, mostly fatty food. There's pyloroplasm, which causes nausea and vomiting. There's flatulent dyspepsia. Patient might have fever. Jaundice might be transient or continuous if in cases of choledocholitis, that's when the gallstone has moved to block the common bile duct. This is a diagram showing a radiation points in patients that present with radiation of pain. You can see most of them have pain at the right hypochondrium, that's 50%, and radiates to the xiphostenum, which is about 64%. About 2% radiates to the right shoulder and to other parts of the body. On examination, the patients are actually ill-looking. There's pyrexia, there's abdominal examination, there might be abdominal stiffness, tenderness at right hypochondrium. The gallbladder is palpable, tender, smooth, soft gallbladder. Presence of Murphy sign. Murphy sign is a sign elicited during mid-inspiration when you're trying to palpate the liver, and you ask the patient to inspire air and hold the inspiration. There's tenderness felt at deep inspiration. Then there's Boer sign. Boer sign is the sign elicited at the back, around the 9th and 10th rib. Is usually in most cases present in patients that have cholecystitis. Investigations that are done in patients with cholecystitis include full blood counts. They usually have elevated WBC. Their packed cell volume might be, if they are severely dehydrated, there might be hemoconcentration. The liver function test, they might have elevated transaminases, elevated alkaline phosphatase and bilirubin levels. There's elevated serum amylase. Imaging, abdominal ultrasound scan is the gold standard. In about 90% of cases, it casts an acoustic shadow. There is pericystic fluid, thickening of the gallbladder, ultrasound Murphy sign, and presence of halo sign in cases where there is gas within the gallbladder. On X-ray, about 10% of stones are radio-opaque and 90% are radiolucent. So in the radio-opaque cases, you might see gas within the gallbladder, You can see Mercedes-Benz sign. These are signs within the gallstone, triradiate gas shadows within the gallstone, within the radio-opaque gallstones. And if the gas shadows are biradiate, it's known as seagull sign. Then limey gallbladder is also seen because of the calcium phosphate are usually radio-opaque. So you see them within the gallbladder on X-ray. So the treatments include hospital admission. The patient should be admitted. Initially, non-operative treatments is advocated for in 95% of cases. New peroral nasogastric tube, sorry for this aspiration, decompression with nasogastric tube, use of intravenous fluids to resuscitate and rehydrate the patient, analgesics, antispasmodics in patients that are having nausea and vomiting. Anticholinergics have also been found to be used because they prevent gallbladder secretion, thereby reducing the pressure within the gallbladder. The use of broad spectrum antibiotics. The patient is strictly observed, input, output, the vital signs, pulse rate, blood pressure. Then follow-up ultrasound scans after the first 24 hours. An ultrasound scan is followed up to know if there is spontaneous resolution or worsening of pericystic fluid. An elective interval cholecystectomy is usually done after 3 to 6 weeks. Yes, then when do you terminate the conservative management? When there is worsening clinical condition over 24 to 36 hours, there's presence of an inflammatory mass per abdomen, there's mucosal of the gallbladder, presence of intestinal obstruction, gas in extrabiliary system, emphysematous cholecystitis, and empyema gallbladder. Now, these are the reasons why you have to do frequent ultrasound scanning of this patient that is on conservative management. If there is worsening of clinical condition, the pulse rate is not coming down, maybe it's going up, urine output is reducing, the person is becoming more febrile or more septic. These are the times to stop the conservative management. The operatives, operative management of acute calculous cholecystitis include cholecystostomy and cholecystectomy. The cholecystectomy is divided into open or closed, that's laparoscopy, or open, which can be divided into partial or total cholecystectomy. The principles of adequate exposure, defining the anatomy, asepsis and hemostasis to exclude spontaneous GI pathologies. Indications of a cholecystostomy: patients that have empyema gallbladder, persisting symptoms or failure of conservative management, patients with emphysematous cholecystitis, which rarely happen, but if they do happen, is an indication to stop conservative management and advance to either cholecystostomy or cholecystectomy in the elderly patients and the severely ill patients. Laparoscopic cholecystectomy, it has fewer post-op complications. The advantages of laparoscopic cholecystectomy include fewer post-op complications. There's short hospital stay. Contraindications to laparoscopic cholecystectomy choledocholithiasis is a relative contraindication, gallstone pancreatitis, cirrhosis. Then the absolute contraindications of laparoscopic cholecystectomy include bleeding diastasis, diffuse peritonitis, amongst others. When do you convert from laparoscopic cholecystectomy to open cholecystectomy? These are the conditions that makes a surgeon to convert. They include no tissue pain. plane, that's loss of anatomy, uncontrollable bleeding, and equipment failure. In these situations, you now have to convert to the open cholecystectomy. Complications of cholecystectomy or cholecystostomy, they include post-op complications, hemorrhage, retained stone. These are recurrence of gallstones within 2 years of surgery, iatrogenic injury to surrounding structures, anastomotic leak, recurrent calculi. That's after 2 years of surgery, the patient presents again with gallstones. Post-cholecystectomy. The differential diagnosis of calculous cholecystitis include acute appendicitis, perforated peptic ulcer disease, acute pancreatitis, acute pyelonephritis, gynecological pathologies like ovarian torsion, diabetic ketoacidosis, myocardial infarction. In conclusion, calculous cholecystitis is the commonest cause of cholecystitis. Although gallstones usually go undiscovered throughout life, the symptomatic presentation needs proper knowledge to make a diagnosis and initiate proper management. Thank you.
Yes, thank you, Dr. Uzo, for the presentation and also keeping to time. So it's now time for comment, questions, and contributions. I can see Prof has joined us. He left a message that his network is very unstable. So Prof, you are welcome, sir. So Dr. Uzo, your slide.
Thank you very much.
You are welcome, sir. Dr. Uzo, you stop sharing the slides. You need to put up your slides.
Yes, I'm doing that now.
Please put up your slides. So the floor is open for comments, questions, and contributions. So if you have a question, please, you can indicate by putting up your hands, or you can just go ahead, unmute your mic and make your comments and contributions. Yes, where are the registrars? The registrars are quiet. Comments, calculus cholecystitis. Comment, questions, contributions. Dr. Magaji, are you there? I can see some registrars, they are just quiet. Dr. Sakina?
Good evening, everyone.
Good evening, Magaji.
Thank you, Dr. Uzo, for your presentation. I have two questions for you. One, I want you to talk about scent triad. Then, secondly, what are the two approaches when doing cholecystectomy, and which one we commonly do in our center? Thank you for the presentation.
Okay. Hello, sir. Can I?
Yes, go ahead.
Yes, sir. Okay. Thank you, Dr. Magaji, for your questions. Your first question is about the sense triad is a triad of gallstones, diverticulosis of the colon, and hiatus hernia. That's what I know about the sense triad. I don't know the clinical relevance though, but I know centroid includes gallstones, diverticulosis of the colon, and hiatus hernia. That's about the centroid. Then the second question was two approaches to cholecystectomy. Then we have the approach via the coca line in action. So I don't know the commonest one used in our center right now.
I'm not satisfied.
So you're not satisfied with which one of them? Here,
But citation.
no, I didn't talk about Charcot's triad, sir.
So the spent heart.
Clinical presentation in a patient of jaundice shows acute cholecystitis or meningitis. The Reynolds pentad includes I can't remember that. So.
Has Charcot triads. What does it signify?
Okay. It signifies acute cholangitis, sir. That's Charcot's triad.
Ascending cholangitis. What is
acute cholangitis, sir.
What is cholangitis?
That's inflammation of the biliary system, sir. Inflammation of the biliary system, I think.
What is the difference between cholangitis and ascending cholangitis? Magaji, I'm just
ascending cholangitis.
What you read. It seems you are not.
Yes, sir.
Dr. Magaji.
So cholangitis is inflammation of the bile duct system, sir. That's the bile and the ductal system.
So what is ascending cholangitis?
So ascending cholangitis results from let's say retrograde infection of the
Sorry, Prof. I'm just trying to pack up the
bladder system.
Oh.
I don't know how to explain, sir.
You see, sometimes when a patient has cholangitis, it ascends to involve the liver. It involves the
yes, sir.
Hepatic biliary system. It has ascended from the common bile duct to involve the liver. So when you palpate the right hypochondrial region, they'll have tenderness. Is that not so? They have jaundice.
Yes, sir.
And because of the cholangitis, the stasis, there they will have fever. So these triads that consist of fever from the sepsis that results from the stasis in the common bile duct, the jaundice, as well as the pain in the right hypochondrium from ascension of the infection to involve the liver, is termed Charcot's triad, and that signifies ascending cholangitis. So what is Reynolds pentad? Pentad is 5.
Reynolds 5. Yeah, renal pentad is including sequelae of mental status changes and sepsis, sir.
There's
Where there
already
is
sepsis. There's
presence of
already sepsis. Sorry, you have tried. Where is Magaji that brought up the question? He now muted himself and he's not participating. Magaji.
Sir,
Chief Bash.
renal pentad.
Hello, sir. Dr.
In
Bashir Yunus,
addition
sir.
to,
Yes, allow Magaji to speak.
so in addition to the Charcot triad, there is presence of mental status change and shock, septic shock. So there is fever, right upper quadrant pain or tenderness, jaundice, septic shock, and mental status change.
It's hypotension, not septic shock. When you bring septic shock, it's an entirely different concept.
Oh, okay, sir.
There are parameters. So you have features of Charcot triad, and now you have hypotension and altered sensorium. Yes, Dr. Ahmed Shehu, you wanted to make a comment.
Chief Bash, it's okay. You have actually explained it. I wanted to put it for them so that they will
please go
understand.
ahead. Please go ahead.
Yes. The general principles in medicine is that most tubular structures in the body encourage free and continuous flow of substances. So in the setting of obstruction, once obstruction occurs, there will be stasis. Once there is stasis, there will be infection. That infection will encourage bacterial proliferation. And particularly, the bile is very rich in triglycerides, as mentioned by the presenter. This will encourage the growth and proliferation of bacteria. Once this growth is limited to the extra hepatic biliary system, then we say the patient has cholecystitis. Once this infection now ascends backward, because the bile is not able to drain into the gastrointestinal tract, then we say the patient has ascending cholangitis. And that's when we have now the Charcot triad of jaundice, right hypochondrial pain, and fever. Then if this thing progresses now, this sepsis progresses, and because most of the organisms that will cause this sepsis are gram-negative, they will lead to hypotension. Once hypotension occurs, there will be loss of sensorium. So you now have Raynaud's pentad. So it's one disease progressing to the next, to the next, to the next, to the next, to the next. Thank you, sir.
Thank you very much, sir.
Thank you, Ahmed Shehu. Well done. Ahmed Shehu from Zaria. So, yes, questions, comments, contribution. Dr. Uzo, are you done with the,
yes, sir,
with the questions asked by Magaji?
Yes, the second question was the two approaches for cholecystectomy, which I said via the Kocher's incision or the midline incision of on the abdomen. That's what he asked me, sir.
That is what he asked you. Magaji, is that what you asked? What do you mean by approaches?
Sorry, sir, I meant methods of used in cholecystectomy while dissecting the gallbladder. You can either use the fundus first approach or the duct first
make your
method.
Clearer. When you say approaches, there is entirely a different question.
Yes, sir, I didn't ask the question well.
Okay. Yes, questions, comments? Please, the registrars, I want the registrars to be participating. You don't just come here and allow Prof to be talking. Allow other, you are the ones that are supposed to be driving these presentations. That's why I'm picking on you. Questions from the residents?
So one more question. How does gallbladder stone causes ileus? Gallstone ileus.
Dr. Uzo, are you there?
Yes, sir.
I believe you have a good network.
Yes, sir.
So go ahead.
It's cause gallstone can cause mechanical intestinal obstruction by impaction. That's how it causes gallstone ileus.
It's not clear.
When there is gallstone ileus occurs due to impaction of multiple gallstones within the lumen of the intestinal tract,
How does it
which
get
can
there?
cause gallstones.
This is in the biliary. Tell us how it gets there. You are confusing us.
So it gets there by when it leaves the biliary system by the normal outflow from the biliary duct into the intestinal tract, sir.
Then that is not obstruction now. Tiny stones normally pass through the anatomical opening into the intestine. Magaji.
Yes, sir.
Go ahead, explain. If not, then Amashu will help us.
Yes, sir. Gallstone at times they form cholecystoenteric fistula. So when that happens, the stone now migrates from the gallbladder into the small intestine, which now causes obstruction at the ileocecal junction. So that's how it causes the intestinal obstruction.
So that is called gallstone ileus.
Gallstone
So who's on the
okay, sir.
Okay. Yes,
okay, sir.
You other registrars are not talking. Chiamaka, ask question. Amadi. Chiamaka, are you there? She has logged out.
So Chief Bash was asking, that's called Mirizi syndrome, isn't it?
No, sir. Mirizi syndrome is occlusion of the hepatic ducts, the left and right hepatic ducts by gallstone within the Hartmann's pouch.
That is precisely, it's not the left and right. It's actually the common hepatic duct.
The common hepatic duct, yes, sir.
And thank you, Prof. And this issue of gallstone ileus is actually not an ileus, right? It's a misnomer. Since it's a mechanical obstruction. Thank you. Thank you, Prof. Thank you, sir.
Please, I want other registrars to participate in this presentation before these consultants make their comments. Karima, too, do you have any question?
Thank you, Dr. Ugo, for your presentation. I did hear you talk about the conversion slope. Can you tell us about it? Thank you.
Uzo, go ahead, please. Dr. Uzo, are you there? Dr. Uzo. It seems the guy has disappeared.
No, I think it's been logged out by network. Network is
Yes, the network is terrible. No, he's not logged out. He's still in.
Maybe we are not hearing him because of poor network.
Okay.
The person that asked, that is a very good question. So there's no way we can talk about so without talking about vicious flow. So the person that asked this question, can you please quickly tell us what are the exceptions?
Okay, he has joined with another device. So you can repeat your question. I think he's with us now. Dr. Uzo, are you with us?
Hello. Yes, I'm here, sir.
Did you hear
for some reason I didn't hear the last question, sir.
Okay,
For some reason I was logged out.
Yes, we saw that. Karimatu, can you repeat your question?
Okay, sir. Thank you, Dr. Ozo, for your presentation. I said, can you tell us about the conversion law and the exception? Thank you.
That's so small.
Uzo, this is completely absent in the presentation.
Sir?
That may be Fonduli's maneuver.
Okay, sir. Let me try. I remember it, but I know it as another name. It says if the gallbladder is palpable, in a jaundice patient is likely not due to gallstones. That's what the law says.
Except, what are the exceptions?
I don't. I can't remember.
It should be coming from. It should be coming at spinal level for a presentation like this. Uzo? Courvoisier's law. Okay, it means maybe you adopted this slide from somewhere.
No, sir. No, sir.
If you read textbook to prepare these slides, I think Courvoisier's law should be coming. I don't think there's any textbook that discuss calculus cholecystitis without bringing that in. Okay, maybe Karimatu will help us out. Since Uzo is claiming he doesn't know.
Okay, hello, sir.
Go ahead, we can hear you.
So the law states that in the presence of jaundice, an enlarged gallbladder is unlikely to be due to gallstone. It's most probably due to cancer head of pancreas. The explanation for that is that usually gallstone with cholecystitis causes fibrosis. So usually the gallbladder is usually not palpable. So in the exception, I'm not sure. I think there is when we have gallstone with associated, I can't remember. So.
Okay, it's very obvious that all the residents are not reading deeply. You just read superficially. That is just my observation. That's why I say you should participate actively so that we can assess your level of reading your stuffs from the responses and questions. Even the presenter, you can see you are not reading deep. So please allow other consultants. I'll allow other consultants to make their observations, their comments, and questions. I don't know even whether Dr. Uzo can answer the questions, but Yes, we'll allow other consultants to make their comment before we give Prof the final, the floor to make his final comments. I can see Chief Dades amongst us. Dr. Ogbo is still among us. So I'll allow the consultants to make their comments, then we'll now leave the floor for Prof to make his comments and contributions. Chief Ogbo.
Thank you very much. The network is not very good. After I asked you the question, I was logged out. I thought I tried before I came back. We tried to, thank you for your presentation. We tried doing justice to what we were given to discuss pathogenesis and management of calculus cholecystitis. However, obviously, in left some places open, and it shows that some understandings were not very, it wasn't very clear to you at those areas. For instance, you say calculus triangle is used for identifying gallbladder. That is not true. Not true. That is what calculus triangle is being used for. When you identify cystic acid within the calculus triangle, there are reasons why that is useful and necessary, because there are so many variations, like you pointed out. I want to make a mistake and see the hepatic acid. You know the complications is what will come out of it. You have a hepatic necrosis and all this, and you need different dose. There are lots of complications and lots of variations in cystic acid and it goes to Mulligan's form. So that's the reason why calculus triangle is used to identify that once you see the cystic acid within that, you are sure injury to hepatic acid is less. Now, we don't quite read about the Cubaceous law.
I didn't get you, sir.
You didn't understand the Cubaceous law. You say it lives in another name. Which, personally, I don't know the other name of Cubaceous law. But you know that Cubaceous law tells us more about if a patient that has jaundice with possibly gallbladder is not likely due to stones. And the exceptions were double impacted stones and give you a possible gallbladder, or a mucocele of the bladder and give you a possible gallbladder. And then when you ask about gallstone ileus, even the person I helped you out, you don't know how the fistula usually come about. How does it form? There is pressure necrosis because there's obstruction, and then the gallbladder is distended, coming in contact with the intestine. So there's pressure necrosis, and there is a fistulous formation between the gallbladder and the small intestine. If the stone drops and cause an obstruction, it is a misnomer, and then it's called an ileus. So generally, the essence of changing some particular topic is not for you to come and it's for you to have information, read about it, so that if it comes out in the exam, you not be looking as if you have never read about it before, and you'll be able to do justice to it. I want to encourage you that after this topic, after this presentation, if you go back and you read this topic, so that it becomes part and parcel of it. Binary tree, I mean the gallbladder of in these relations. It's quite interesting because it can be very difficult. So you need to read about it and have a good grasp of it. Thank you very much.
Thank you very much, sir.
Thank you, sir, for your comments and contribution. Chief Darius.
Okay. Can you hear me?
Yes, sir.
We can hear you, sir.
Okay. Good evening, Prof. Good evening, all. Thank you, Bashir, for
My HOD.
for my HOD, sir. So, thank you, Dr. Uzo, for the presentation. I don't, you're not sharing your slide. I would have loved to have a look at your outline. But looking at the question, which
Okay,
is
sir.
pathogenesis and management of calculus cholecystitis. So there are basically the key thing. One is the pathogenesis and then management. So it's more of a management question. So possibly an introduction, then pathogenesis, then the management. Yeah, you had the definition, epidemiology, but possibly needed to say something about this. I mean, a statement of surgical importance. Why are we even discussing calculus cholecystitis? Particularly how it affects morbidity and mortality, so, and then the pathogenesis. The management, you left out resuscitation completely. Acute calculus cholecystitis, most times they come as emergencies, which you need to resuscitate in the emergency. And so that should have been one of the first things you discussed under management. Before, of course, making the diagnosis, with history, physical examination, the differentials, the various treatment options for the various forms that may present, and the complications of treatment and other things as well. So, but be that as it may, Dr. Felix had talked about the callus triangle. I think the borders, the border you talked about using the common bile duct as a border of the callus triangle. Well, possibly you meant the common hepatic duct, even though I know there are some variation with respect to the borders of callus triangle, so, but I'm not sure if common bile duct is generally accepted as a
common
border
hepatic duct.
Yeah, so that's that. So, and I also talked about formation of stones within the cystic duct. And I think when you're discussing something about, is it the etiology or something, but I think it's more of those stones are formed within the common bile duct, but they migrate to the cystic duct. That's where they now cause blockage. And then the series of events that occur with distension, empyema, mucocele, and the rest of them.
Yes, sir.
Yeah, so I think under this still under etiology, talked about asymptomatic stones, and you gave a percentage of 10 and 20%. I think asymptomatic gallstones, I mean, the most common forms of cholelithiasis. So I'm not sure if that percentage, the percentages you gave are correct for asymptomatic.
Sorry, sir, it's more asymptomatic, but symptomatic in 10% of males and 20% of females.
Okay.
Symptomatic in
all right.
Yes, sir.
All right.
That's what I meant, sir.
Yeah. Okay. All right. Well, that's okay then. So, and then I think at the point we're talking about the contraindication to laparoscopic indications for, contraindications to, the indications for cholecystostomy. Yeah, I was wondering because we hardly do cholecystostomy now because usually it's in patients who are not fit for surgery. You want to do the minimum for them.
Yes, sir.
You just put this, but you seem to have so many cirrhosis as one of your indication for cholecystostomy. So I'm wondering if that is, I know that medicine is dynamic, but cirrhosis, sometimes even in patients who are asymptomatic with liver cirrhosis, sometimes it's an indication for cholecystectomy for them, so I don't know if you have any reference for that. Just as part of getting to update our knowledge. And then contraindications, we have mentioned contraindications to laparoscopy. Virtually these days, virtually anything can be done laparoscopically. So some of those contraindications we listed may not be true in certain circumstances, because where the expertise is available, everything that's available, they can do almost everything laparoscopically. So just to take note of that. And
okay, sir.
Yeah, so I think basically these are some of my observations. Even though you have tried, but you didn't seem to show mastery of the subject matter. We expect you to, give some more information, display mastery of this subject. I'm sure you must have been given enough time to prepare for this. So you should master in such a way that even after this presentation, even if you don't get the time to read it, the residual knowledge should be able to you should be able to use it during exams and pass. So that's the essence of this presentation. So you have enough time to read and master the subject matter. And when you're doing revision, meaning that you have had a vision before, now you're doing revision, it shouldn't take too much time, and then you will recall most of these things that you have learned and have been taught. All right. Having said that, thank you all. Thank you for
thank you very much, sir.
Thank you, sir, for your wonderful comments and contribution. I had Chief Dades is asking you for a reference in a particular information when you don't even have a single reference. Your slide, there's no even reference.
Sorry, sir. I didn't add my reference. Sorry, sir. I can update it.
And then something I left at is the issue of the treatment, which is actually what I wanted him to talk about, the various treatment options for acute cholecystectomy. Do you do urgent cholecystectomy, emergency cholecystectomy, interval cholecystectomy? When and why do you do all those things? I don't know if you have answer to that question.
Okay, sir. Okay, sir. A majority of acute calculus cholecystitis is treated conservatively. About 95% of them resolve. Then delayed. That's elective cholecystectomy is done 3 to 6 weeks after. An emergency cholecystectomy is done if the conservative management fails. That's patient's clinical signs are worsening, or if there's presence of empyema gallbladder, if there is perforation or peritonitis in such patients, you go ahead to do an elective cholecystectomy, sir. Hello, can you hear me, sir?
Yes, Dr. Uzo, we can hear you.
Yes, sir.
Yeah. So I think there are a lot of issues you need to go and review in this topic.
Okay, sir.
That is mentioned.
Okay, sir.
Supposed to demonstrate mastery of this topic, because of course there are so many areas you do not really touch. As you said, of course, the uncomplicated cholecystitis might resolve within a few days if the stone is not impacted. They might resolve, but when they are complicated, usually the outcome is bad, and this lead to those complications that will present as an emergency that you might intervene, like perforation, peritonitis, gangrene, and so on. They are so, and in initial diagnosis, you should have added acalculous cholecystitis, because
yes, sir,
there are some conditions which may cause stasis of the gallbladder. Okay, like patients with uncontrolled diabetes mellitus, HIV/AIDS, okay, or patient with retroviral,
yes,
okay, trauma, and some conditions, they cause features of acalculous cholecystitis from stasis, patient on prolonged parenteral nutrition and so on. So it's a differential diagnosis that you should consider. When you scan them, you see distended gallbladder, but you will not isolate any slough or any stone that is causing obstruction. That
Okay, sir.
So you should add that to your differential diagnosis.
Differentials. Yes, sir.
So I think we'll hand over the presentation to Prof to make his final comments on the presentation. Thank you, sir.
All right, thank you very much, Abash, and thank you, Dr. Uzo, for your presentation. There are two parts to this question. One is a pathological question, typical surgery question. One is pathology, the other is surgery. And it's always so when we talk about gallbladder, there are always these two parts, the pathology and the surgery. So
yes, sir.
I think I came late, I must confess, but when I saw you going through this, I realized that you need to read a bit more about the pathology, including the pathogenesis and the physiology. That way you will be at home with what is going on. Now, the reason for understanding the pathophysiology is that you can now unwind and decide on what treatment, what investigations, and so on, once you understand this. And there's no other place that is as good in describing this as this particular organ we're discussing. My second point is that you see about the pathology. There are other pathologies around here that you really ought to master. Gallbladder disease is not true that it's not common now. It's not seen now. We are increasingly seeing, we are having a modification in our lifestyle that is making things that used not to be seen before to be seen now. So yes, it's not as common as we find elsewhere, but we are seeing increasingly, it's not Dr. Dades will tell you, this is not an uncommon subject. It's actually quite common. We're seeing it increasingly. Now, when you discuss this kind of subject, again on the pathology, look at what is more common, what's the epidemiology of the disease. So I came late, so I don't know if you had a segment on sickle cell calculus disease or not, but if you did you discuss the kind of stones that you are going to encounter or you didn't? Because you ought to do that also. Now you find they will ask you questions about the complications that arise from stone formation in this area. You were pretty dry in most of this, even the Courvoisier's law, which is commonly mentioned here, you were unable to spell out some of the details around it, as Dr. Ogbo was trying to draw your attention. Mirizi syndrome, for example, the initial description were 4 types. Now we have a number 5 that Bertrand introduced. I don't see how a postgraduate student would discuss gallstones without mentioning about Mirizi syndrome. Somewhere along the line you should, to demonstrate your showmanship that you understand the subject. So when you come to the surgical aspects, you can hear Dr. Dades drawing your attention to 2 very important things. For example, you talk about, I can tell you some mnemonics when you come to operative surgery. We didn't actually ask you to discuss in detail the operative surgery, but management means you're not just restricting yourself to investigations and so on. You're coming to treatment and treatment modality. So I expected that you would decide if you're going to do an open operation, how would you approach it? You should say that to us. If you're going to do, in fact, there are some things about clinical presentation. I don't know if you actually attempted to do that. Gallbladder disease is supposed to be fairly more common in females than in males. I don't know if you gave us some clinical information about what to expect in a patient with this kind of disease before you end up, operating. But I want to say that clinically,
Hello, sir.
sorry, I broke off my network as I told you. I'm sorry. Can you hear
Yes,
me?
sir. We can hear you now, sir.
Okay. Sorry about the network challenge I had. So I think that you needed to. You may not describe much about laparoscopic procedures, but I expected you'd say something a little bit more about your expertise or what you have watched in open cholecystectomy for gallbladder disease. For example, here is a place where, as you are talking about stones and talking about stones, not just in the gallbladder, but getting into the common bile duct, you should be telling us about what to do about stones in the common bile duct. When do you explore for those stones? What do you do about them? So
Yes, sir.
in conclusion, I would expect that, and this goes for everybody really, any one of the residents. When they give you a topic like this to present in 30 minutes, please come and do your work to last you for 1 hour. In the exam, you have to write this essay for 1 hour. Write it so that you will include everything that should be included. You can now extract that for this presentation. And when they ask you questions, you should be able to get back to your original notes. Like Dr. Dadeza said, that will be visiting the subject. When you are going to prepare for your exam, you'll be revisiting the subject, updating the knowledge, and so on and so forth. But if for this presentation, you have only a brief preparation, it will not be good enough. And you have a lot of areas you have missed, which is the point we're trying to draw your attention to. So
Yes,
I think that you have tried, but it's very much superficial. It's just not high enough above MBBS. I will put it this way. I think you should try and make it like what a resident who has been in surgery we should be able to say, So again, let me make this suggestion to all residents. This topic or any other topic at all, when you find that you have seen the thing physically, you have even assisted, you can talk about it more confidently than if you just read it in the book, which is what I'm seeing this evening. So anyway, you hear they're going to do gallbladder operation, I think you should go there and be part of it.
Yes, sir.
So in your further reading, you'll be talking about when to with indications for exploring the common bile duct. You'll be talking about other things that can block the common bile duct. It's not just about stones. Stones can be there. Some other things, worms can also block that. And so
Yes,
you'd be better enriched. We're talking about gallbladder. So every disease of the gallbladder you should know, including cholangiocarcinoma, cholecystitis, carcinoma of the gallbladder, you should know. Cholangiocarcinoma, you should know.
Yes, sir.
In this presentation, you may not use it for
Hello, sir.
thank you very much. I think that's enough warning to say that I should come down. I think I made a point.
Prof.
Thank you very much.
Thank you so
Yes,
much,
sir.
Prof.
Yes, sir. Thank you very much, Prof. Thank you, sir.
Thank you, Prof.
Okay, thank you very much, everyone, for the comments, contributions, and questions. And I must thank Prof for his tireless effort in educating this house on most of the surgical conditions that are being discussed. We really appreciate your comments, your consistency in joining our presentation and educating us. We don't know how to really appreciate you for your efforts. And it is obvious that the residents, you need to really put more effort in your readings.
Yes, sir.
And preparation for all these topics, because these are same topics you encounter in your exams. The examiners don't go and synthesize new topics. It is still the same topics that we are discussing here. It is same topics that you encounter in your exam. So I will encourage all of you to take all this seriously. When you are giving a topic, I'm talking to the presenter alone, all the residents, you have to really study this topic in depth, as Prof has emphasized. So
Yes, sir.
without taking much of our time, we are going to stop here. I must thank Dr. Dades, Dr. Felix Ogro, and other senior registrars from other centers. I can see Dr. Ahmed Shehu from Zaria, and who else? There are some senior registrars here who did not identify themselves, but we have Ahmed Shehu from Abubakar Gali. Is he a senior registrar? Abubakar Gali, you did not see anything throughout.
Thank you, sir. Thank you. Sorry, I'm not a senior registrar. I'm a registrar too. So,
Okay.
but next time, sir, I'll try and participate fully, sir. Thank you.
You are from which center?
I'm from University of Medical Teaching Hospital.
Okay, well done. You are welcome. Karima from National Hospital. And do we have any other senior registrar in the forum? Okay, Eze did not join today. So thank you, everyone. I'm going to update us on the next topic for next week. So thank you very much. Thank you, Prof. Good night, all. Chief Dades, good night, sir.
Good night, sir.
Thank you very much, Chief Bash. Chief Bash, we appreciate the rally.
Welcome.
God bless you.
Yes.
Thanks a lot.
Thank you.
Good night, everyone.
All right.
night.
Good night, sir.
Good night. Good night.
Thank you, sir.
Good night.